All right, let's begin then. मलिया जी आवाज क्लियर है मेरी? हेलो, मेरा आवाज ऑडिबल? इज माय वॉइस ऑडिबल? Okay. All right, let's then begin. Yesterday we finished about the GIT, and yesterday one of the students asked me about progressive dysphagia in achalasia. So yeah, in achalasia I checked in surgery. It was liquid first and then solid. Okay, so you also just check it once in your notes and then let me know. Okay, so today we'll begin the liver part and gallbladder, and along with that pancreas. Okay, so these three pathologies we will be discussing today. The first one is liver, and then we are discussing about cirrhosis and portal hypertension. So one of the most common cause of cirrhosis is portal hypertension. Okay, so let's just see what is given over here. Diffuse breathing, fibrosis by stellate cells and regenerative nodules disrupt normal architecture of cells. Okay, increased risk for hepatocellular carcinoma can lead to various system changes. Etiologies include alcohol, non-alcoholic. The most common cause is portal hypertension, alcohol, and viral hepatitis. And in hepatitis, the C is the hepatitis C is the most common that will lead to cirrhosis and then hepatocellular carcinoma. Whereas B, A and E to karte hi nahi hai. B it takes time. Okay, it can resolve on its own also. Mostly the cases resolve on its own, but C definitely will occur. Now let's see what is given in portal hypertension. Increase in pressure in portal venous system, cirrhosis and all those things. Okay, so यहाँ पे कुछ ज़्यादा you don't have to study much in detail over here. What you need to know is remember this diagram. They will give you the features and then they will ask you where is this in seen. Okay, or else they will ask you what is the pathology behind it. So if they ask you about the cirrhosis, and then they will be asking you what is the most common cause that can cause this condition. Okay, so they will be asking you stuff like this. So let's just see. It may say important concepts. See, these are the basic normal one. These are the normal one. This normal. So the something unique one is spider angioma, palmar erythema, testicular atrophy, and gynecomastia. Why they are unique? Because in UL there is one question in UL, and in exam, in the real exam I got this question. What is responsible for these symptoms to occur? What is responsible for this clinical presentation? So your answer is due to increase in estrogen. Okay, this is very important. It is asked in UL. It was asked to me in exam. I think NBME also has this one or two questions like this. So make sure you know this properly. Pseudoangioma, palmar erythema, testicular atrophy, and gynecomastia. All these four are very important. Rest all are very common. Okay. So in cirrhosis and portal hypertension, I would say this diagram is very important. Okay. Let's just move ahead. Spontaneous bacterial peritonitis you can avoid. No questions have been asked till now. Let's just see the serum markers of liver pathology. The serum markers there are AST, there is ALT, there is ALP, and gamma GGT. Okay. Now just one thing, if the problem, if you have seen BNB properly, they have explained it very beautifully how to know whether the problem is in liver, how to know whether the problem is about some biliary or gallbladder. Okay, so if the values of AST and ALT are greater than ALP, it means it is a liver problem. Okay, this is the basic information while solving the question. And if ALP is greater than AST or ALT, then it is biliary problem. Okay, this is the simple thing that how you can distinguish whether the problem is in liver or whether the problem is in gallbladder. Okay, I hope you know this stuff. Now let's move on and just see a few points over here. In AST, increase in most liver disease. Okay, and this is ALT. In alcoholic liver disease, you have AST, whereas in normal disease, you have ALT. How to remember? Toast. AST, toast with alcohol. You make the toast with alcohol. So, AST. Okay. And yeah, it should not exceed 500. Both AST and ALT should not exceed 500. If it is exceeding 500, if the values are in thousands, then you should think about some other causes, whether it is fibrosis or cirrhosis or ischemic hepatitis or viral hepatitis or drug-induced liver injury. Okay, so अगर thousands की range में आता है, if the value is in thousands, then there is no like problem like alcoholic hepatitis and something like that. No, the problem is something else. For example, drug-induced injury, viral hepatitis, ischemic hepatitis. Okay, so all this stuff. Thousands की range में आया, so think about this. And if it is around 500, then think about well, maybe due to alcohol or some other stuff. Okay, this is the one important criteria. ALP increases in cholestasis. Okay, तो biliary problem में ALP increase. Gamma GGT increase in various liver and biliary disease, but not in bone disease. Okay, that's it. Functional liver biomarkers or markers: bilirubin, albumin, prothrombin time, and platelet. Just albumin and platelet decreases, bilirubin and prothrombin time increases. Okay, so this they won't ask frequently, but this they will definitely ask. Most common being AST, ALT and ALP. इसमें आपको डिस्टिंग्विश करना आना ही चाहिए और else प्रॉब्लम हो जाएगी. Okay, so now moving on to the next question, next topic, that is Reye syndrome. Reye syndrome, often childhood hepatic encephalopathy. Here they will always give you one case that the child plus viral infection and he was given aspirin. This is the only case that is asked in Reye syndrome. इसके अलावा there is no other case that can be asked for the Reye syndrome. Okay, let's just see what all information is there. Associated with viral infection. Okay, so varicella zoster है, so they can say that the child had shingles. Okay, shingles, varicella zoster, chicken pox में you have shingles. So shingles है, उसके बाद parents ने उसको aspirin दे दी. The parents thought of giving aspirin to the child who was suffering from varicella zoster, and as a result, this problem occurred. Okay, so aspirin metabolite decreases the beta oxidation by reversible inhibition of mitochondrial enzyme. This line is very important. Okay, this line is very important. This can be asked in the form of pathophysiology. The findings are mitochondrial abnormalities, fatty liver, hypoglycemia, vomiting, and hepatomegaly. All these are the findings. This line is very important. And what should we do? Avoid aspirin in children except in Kawasaki disease. In Kawasaki is a type of vasculitis. Okay, it is a type of vasculitis that we will do in musculoskeletal. So उसमें treatment is aspirin plus IVIG. Okay, immunoglobulin intravenous IgG. Okay, that's it. ये आपके high yield points हो गए, and this is the case. And varicella zoster is there, so they will give singles, and then they will say the parents gave aspirin to the child. Okay, so this is very important. All right, moving ahead, alcoholic liver disease. So there are three things you need to remember here: hepatic steatosis, then alcoholic hepatitis, and alcoholic cirrhosis. So steatosis में क्या है? Macrovascular fatty change that may be reversible with alcohol cessation. Okay, So macrovascular fatty change you have to remember. Second, alcoholic hepatitis requires sustained long-term consumption. Swollen and necrotic hepatocytes with neutrophilic infiltration. Mallory bodies, that is intracytoplasmic eosinophilic inclusions of damaged keratin. This line is very important. Mallory bodies क्या होते हैं? So intracytoplasmic eosinophilic inclusions of damaged keratin, because instead of Mallory bodies they might give you this line and you should be able to identify them. Okay. Let's just see at the image that they have given here. See, these are the fatty changes. Now, one general rule of pathology I want you to apply. ये रूल को आप याद रख लो. Whatever system you solve, okay, whatever system you solve, if on biopsy you see white white globules, okay, ऐसे white globules, if you see something like this, they are talking about steatosis or anything related to fat. Okay, this is the general rule. अगर आपको histology or in biopsy you are seeing this white globule, it means they are talking about some problem related to fat, or there is fat deposition, or there is steatosis. Okay, so remember this rule. Coming to the alcoholic cirrhosis, final and usually irreversible form, sclerosis around the central veins may be seen in early disease. Now yesterday we talked sclerosis is caused by the stellate cells of liver. Okay, so sclerosis is caused by the stellate cells of liver. Regenerative nodules surrounded by fibrous band in response to chronic liver injury, so portal hypertension and end-stage liver disease. Okay, so they will just give you this image and then they will ask you what cells are responsible for causing this of a process. So you can say the answer is stellate cells of liver. All right, to note this down. This is important. Moving ahead, we have non-alcoholic fatty liver disease. Again, here fat is there. You can see in this hepatocyte there are many white globules. So this means fat का कुछ issue है, and the name itself is saying non-alcoholic fatty liver disease. Okay. So fatty infiltration of hepatocytes, cellular ballooning, and eventual necrosis. Okay. This is not associated with alcohol. Not associated with alcohol. Okay. And ऊपर this will be associated with alcohol. So यहाँ पे AST will be greater than ALT. Okay, AST greater than ALT, but here AST ALT will be mildly elevated, not so much. Okay, they both will be mildly elevated and both will be, close to each other. मतलब इनकी values क्लोज होगी, किसी की ज्यादा नहीं किसी की कम नहीं, ऐसा कुछ नहीं होगा. समटाइम्स इट माइट हैपन कि ALT का वैल्यू ज्यादा हो जाए AST से, समटाइम्स दे में से, बट you need to remember that it is independent of alcohol. Okay, moving on to the autoimmune hepatitis. So autoimmune hepatitis is a new topic that they added in this edition. In 2020 it wasn't there. The histology is portal and periportal lymphoplasmacytic infiltrate. This question was there in UVL as well as in NBME. That's why they have added over here. Okay, lab increase in ALT and AST, and as it is autoimmune, the values will be in thousands. Okay, values will be in thousands. All right. Moving to hepatic encephalopathy. In hepatic encephalopathy, you have cirrhosis, photosystemic shunt, decrease in ammonia metabolism. So ammonia का metabolism कम है, so there will be increase in ammonia in blood. So it might lead to neuropsychiatric dysfunction. Okay. So as ammonia is increasing in the body, there will be flapping tremors also. That we give the name of hysterexis. Okay. We have seen this in biochemistry in hyperammonia condition. Hyperammonemia condition. Okay, so just recollect all those stuffs and think if ammonia is increased in the body, what can happen. Okay, so one important thing that they ask here is NH3 production and absorption, increase in NH3 production and absorption and decrease in NH3 removal. How, like, what are the reasons for this? So reasons are due to GI bleed, constipation, infection, and for decreasing NHC removal, you have renal failure, diuretics, and bypass hepatic. So this is important. Why? Because they will give you, in the case they will give you these conditions, and then in the options they will ask whether there was problem with NH3 production and absorption, or there was problem with NH3 removal. Okay, they will be asking questions like this. So these brackets are very important. And the treatment you have, lactulose, increase in NH4 generation, and rifaximin, decrease in NH3 production, gut bacteria. So this is very important. They have asked about the treatment, they have given the cases, and they have asked what is the mechanism behind it. So this is very important. All right. So that's all for this page. This page is very important, as can we see from the information. All right. Let's move ahead. Liver tumors. So let's just see the one important line that you need to remember for each of these tumors. The first one, hepatic hemangioma, cavernous hemangioma, most common benign liver tumor. Most common benign liver tumor. Biopsy contraindicated because of risk of hemorrhage. So here they will say uh, what should not be done. In the UL only they have asked this question. What should not be done? Okay, so you should remember biopsy should not be done because of risk of hemorrhage. Coming to the second type of liver tumor, that is FNH, focal nodular hyperplasia, second most common benign liver tumor. Age you need to know. Hyperplastic reaction of hepatocyte to an aberrant dystrophic artery. This is important and marked by central stellate. Okay, these 2 points are important. Moving to the third, that is hepatic adenoma, rare benign tumor often related to oral contraceptive or anabolic steroid use. ओरल कॉन्ट्रासेप्टिव और एनाबॉलिक स्टेरॉइड यूज की वजह से एडिनोमा होता है. Okay, that's it. The symptoms, they might ask you abdominal pain and shock. They might give the case of the female patient using OCD or a male gym going patient using steroid. Okay, and if they gave you abdominal pain and shock, think about hepatic adenoma. Coming to the most important, that is hepatocellular carcinoma, also called hepatoma. Okay, also called hepatoma, most common primary malignant tumor in adults. Okay, associated with HBV and other causes of cirrhosis, including HCV, alcohol, autoimmune, hemochromatosis, all those examples. Okay, the most important being here is aflatoxin from aspergillus. Aflatoxin from aspergillus. Aspergillus is a fungi. So sometimes how they will give you the case over here is they will say again, you went for hiking, you went for hiking, your food got finished, you paid mushrooms, but it was aspergillus, and the toxin removed from that was aflatoxin, and as a result, you got hepatocellular carcinoma. So this case might also be given. So be aware. You can be asked anything. Coming to findings, there will be anorexia, jaundice, hepatomegaly, may lead to decomposition of previously stable cirrhosis and all those stuff. Okay, this is normal. One important point is spreads hematogenously. It spreads hematogenously. Diagnosis is ultrasound or CT MRI, not asked. Okay, yeah. So that's all for the hepatocellular carcinoma. Coming to hepatic angiosarcoma, one year important line is exposure to arsenic and vinyl chloride. This vinyl chloride is very important. They will give you in the question that a patient was exposed to vinyl chloride. What can be the diagnosis now? So answer will be hepatic angiosarcoma. All right, then that's it. That's it for this is how the image will be looked. An image will appear, and so liver tumor, I'll mark it as high yield. Okay. Moving down to Budd-Chiari syndrome, you can basically ignore. No questions have been asked regarding this. Okay, so just ignore it. It is a part of step 2 CK in surgery. They have asked a lot of questions, but now in step 1 they won't ask. Coming to alpha 1 antitrypsin deficiency, just forget all those stuff. Just remember if in the question they give you emphysema along with liver fail. Okay, then you will think about antitrypsin deficiency. Okay, So this emphysema was because of pen SNR emphysema. Okay, we did this in the respiratory pathology. Okay, so if in the case they give you emphysema plus liver fail, sometimes they directly won't give emphysema, they will give you FEV1 by FVC values, and you have to diagnose whether it is COPD or RLD. And based on that, if it is COPD, then you have to think about emphysema. And apart from that, they ask along with this lung problem, what will be the problem in liver? So you should say alpha antitrypsin deficiency. Okay, so this is important. Coming to jaundice, so the common causes of increase in bilirubin, these are important: hemolysis, obstruction, tumor, and liver disease. Okay, so in jaundice ka, you know the common feature, that is yellowing of skin and sclera due to bilirubin deposition. Okay, simple. Now, as we did this in the physiology, I told you ki remember that flowchart diagram. Okay, so before you start this, just go back and read this diagram, just give it a look, and based on that, uh, just understand what enzymes are deficient, what will be the effect of all those enzymes. Okay, so conjugated means direct, unconjugated means indirect. So these are the causes that you can remember. This is one enzyme given over here, beta glucuronidase, lysosomal enzyme that deconjugates direct bilirubin. Okay. Also found in intestinal brush border and in breast milk, sometimes leading to neonatal unconjugated hyperbilirubemia. May lead to pigment stone formation. This is just the normal information, not high yield. But just remember that if we is talking about direct, it means conjugated also. If it is talking about indirect, it means unconjugated also. So don't get confused. Benign neonatal hyperbilirubinemia. Okay. So this is the new thing in this edition. In 2020, they didn't give this. In 2020, they gave the separate topic, physiologic neonatal jaundice. Let me see it given. Okay, let's just see what is given here. Formally called physiologic neonatal jaundice. Okay. Mild unconjugated hyperbilirubinemia. It is given unconjugated over here, so no need to think anything else. So why it can occur is increase in fetal RBC turnover, increase in hematocrit, and decrease in fetal RBC lifespan. So you know this bile indirectly it is coming from hemoglobin only. From the hemoglobin metabolism, it is going and coming. That is what happening over here. Immature newborn liver, that is this enzyme will be absent. Sterile newborn gut, that is there will be decrease in conversion. Okay. It occurs in all newborns after first 24 hours of life, and it usually resolves without treatment in 1 to 2 weeks. Okay, so this is what you need to remember. You can ignore this stuff, but this is very important. How to distinguish between physiologic neonatal jaundice and biliary atresia. The next condition that we'll be studying is biliary atresia. So in both of them, you will be confused. So one thing is, you can remember a timeline. If it is problem is occurring in the newborn in the first 24 hours of life, then think about physiologic neonatal jaundice, that is benign neonatal hyperbilirubinemia. Now let's see about biliary atresia. The biliary atresia occurs after 2 weeks of life. Okay, whereas in physiological neonatal jaundice, it occurs within the first 1 to 2 days of life. So based on this, you can make the diagnosis. Second thing, in biliary atresia, what else occurs? Darkening urine, acholic stools, and hepatomegaly. This is very important. Acholic means light brown stools. Okay, the stools are maybe colorless or very light brown. Okay, that's what means acholic without color. Okay, and in labs you have direct bilirubin and GGT, but nothing sort of this is seen in neonatal jaundice. Okay, so you need to remember a timeline, and this or everything you need to remember. And one important point, this is the most common reason for pediatric liver transplantation, and they were even asked this: fibro-obliterative destruction of bile duct. So each and everything over here is important. They have asked in NBME as well as in UL many times. Okay, so this is how you will be distinguishing between neonatal jaundice and biliary atresia. I think now there won't be mistake. I'm solving this type of question. Now next is hereditary hyperbilirubinemia. Hereditary hyperbilirubinemia. First of all, you need to remember they all are AR, autosomal recessive. Okay. Now let's just see one by one how the cases can be presented to you in Gilbert syndrome. In Gilbert syndrome, what they will say is they will literally give you this stress, illness, or fasting. Whether the patient is in stress or the patient was fasting. Okay, so fasting and stress are very important. If you find this in the question, and if they say the increase in unconjugated bilirubin, straight away go for Gilbert syndrome. Okay, so stress, fasting, and increase in unconjugated bilirubin. This is what the diagnosis of Gilbert will be. Coming to second, Crigler-Najjar syndrome type 1. So here there will be absent of this enzyme, but in Gilbert syndrome it was there, but it was of low level. Okay, look at the difference. Low level and absent. What happens over here is the findings will be jaundice, kernicterus, increase in unconjugated bilirubin. Okay, so treatment they don't really ask, but you can just write plasmapheresis and phototherapy. Just remember. And type 2 is less severe and response to phenobarbital. This is important. They have asked this. Okay, so here complete absent, but here it was mildly decreased. Both have unconjugated bilirubin, and in addition to another differentiating features are in Gilbert you will be given either a patient was fasting or was in stress, whereas in Crigler-Najjar they will give jaundice, conductor as all those stuff. Okay, now coming to Dubin Johnson syndrome. So in Dubin-Johnson, you have conjugated hyperbilirubinemia. Okay, due to defective liver excretion, it is grossly black due to impaired excretion of epinephrine metabolite. Everything is very important and high yield. Okay, now one thing how you will distinguish from Rotor syndrome is the liver is normal, and other due to impaired hepatic storage of conjugated bilirubin. So difference between Dubin-Johnson and Rotor syndrome is in Dubin-Johnson and Rotor syndrome, first of all, both are having high levels of conjugated hyperbilirubinemia. Second, in Dubin-Johnson, there is defective liver excretion, whereas in Rotor, there is defective liver storage. Okay. Third, impaired excretion of epinephrine metabolite in Dubin-Johnson. That's it. Fourth, liver is very dark black in color in Dubin Johnson, whereas it is normal in Rota syndrome. So these are the four types of hereditary hyperbilirubinemia, and these are very, very, very high yield. Definitely one or two questions will be coming to. Okay, so I hope now this will be clear to you solving this question. Wilson and hemochromatosis, another very, very high yield topic. So as I told you yesterday, in GIT, everything is high yield, whether you go for step 2 CK or step 1 or NEET PG exam, surgery and everything. CIT is very big and very, very high yield system. You should be knowing most of the details over here. So now coming to Wilson and hemochromatosis, for example, you have given the case of Wilson or hemochromatosis. Now you want to distinguish whether they are talking about Wilson or hemochromatosis. Okay, so we should be knowing what they are talking about. So if we are not understanding the symptoms and nothing else, just look at the age of patient. Okay, Wilson presents before the age of 40, whereas hemochromatosis presents after the age of 40. This is a very important early differentiating point that can be seen in both these conditions. Okay, whatever the questions I have solved, they have followed this rule. 40 के ऊपर है तो hemochromatosis and 40 के नीचे है तो Wilson. Okay, so this is very important. You can take this into consideration. Let's just see what is happening. Also called hepatolenticular degeneration. AR mutations in hepatocyte copper transporting ATPase. Hepatocyte copper transporting ATPase. Okay. Chromosome 13. So decrease in copper incorporation into apoceruloplasmin and accretion into bile and decrease in serum ceruloplasmin. These arrows are very important. Okay. So copper accumulates in the body. Copper level increase in the body, and as a result, urine copper also increases. So all of this is important. Okay. Now moving to the symptoms, how they will be presented to you. It can be liver failure. It can be neurologic disease. It can mostly they will ask you about tremor or Parkinsonism. Next, psychiatric disease, and this is very important. Kaiser Fletcher ring. Kaiser-Fleischer ring that is deposits in the cement membrane of cornea. Okay, this is what Kaiser-Fleischer ring looks like. It is also called sunflower cataract. Okay, that's it. That's it. What you need to remember. And treatment is important. Chelatin with penicillamine. Just penicillamine is important. Okay, so all these points that we have discussed here is very important. And sometimes the symptoms you will feel same, they are actually not same, but sometimes in the stress you might feel that what he's talking I'm not understanding, but you get the idea that he's talking about Wilson or hemochromatosis. So just look at the age of a patient. If it is less than 40, Wilson; greater than 40, hemochromatosis. Now let's come to the hemochromatosis. This is also AR. Mutation in HFE gene located on chromosome 6 lead to abnormal hepcidin production. So low hepcidin production, so it means intestinal iron absorption is increased. So there will be iron toxicity. Okay, because of low hepcidin. Simple term. Low hepcidin, iron toxicity increase. Alright. So when the total body iron is greater than 20 gram, iron loss through menstruation slows progression in female. Okay. So females have an advantage over here. They have asked this question also. Okay. So males may it is most commonly seen. You have to remember one triad over here, classic triad of cirrhosis, DM, skin pigmentation. Bronze diabetes is important. Also causes restrictive cardiomyopathy, dilated cardiomyopathy, hypogonadism. Hypogonadism is very important. Okay, hypogonadism. In UL, there is one question regarding hypogonadism. And HCC is the common cause of that. Treatment is phlebotomy, iron chelated with deferoxamine. See this drug, they have Fe in them. That means Fe means iron. Okay, मतलब iron को निकालना है. So this is what you need to remember in Wilson and hemochromatosis. In hemochromatosis, in UL and in NBME, they have focused more on one question, and that is along with this there is decrease in libido. There is decrease in libido, and they will ask in which of these condition this is occurring. Okay, so these two conditions done. Now coming to biliary tract disease. Now we'll be talking about the gallbladder problem. Now, if there is a gallbladder problem, if there is a biliary disease, biliary tract problem, so you can say that the ALP is going to be greater than AST and ALT. Okay, so this is what you will be following now onwards from the biliary tract disease. May present with pruritus, jaundice, dark urine, light colored stool, hepatosplenomegaly, typically with cholestatic pattern of LFTs. Okay, cholestatic pattern means ALP is greater than AST or ALT. So increase in conjugated bilirubin, cholesterol, ALP, what this is what we talked in short. Okay, so PSC and this is PBC. Very important conditions. Okay, let's just see what they want to ask to us. So in let's just discuss first PSC. PSC most commonly occurs in males, PBC occurs in females. This is one etiological factor that you can find it out. Okay. Second, PSC is associated with ulcerative colitis and PBC is an autoimmune condition. If it is an autoimmune condition, there has to be auto antibodies. Okay. If it is autoimmune condition, there has to be auto antibodies present. Okay. Now let's see other things. In PSG, there is onion skin bile duct fibrosis. So here there will be involvement of both intra and extrahepatic bile duct, and the diagnosis is through MRCP/ERCP. Okay, so this is important. Diagnosis MRCP/ERCP, intrahepatic as well as extrahepatic bile duct will be involved. Now moving on to PBC, here most commonly intrahepatic will be involved. Okay, most commonly intrahepatic will be involved. Okay, so this is one difference, and yeah, this will be associated with ulcerative colitis, and this is autoimmune disease. Another thing, mark another general rule of pathology. One autoimmune condition can co-occur with other autoimmune conditions. Okay, so if primary biliary cholangitis is occurring, then the patient can also have celiac disease or the patient can also have rheumatoid arthritis. This is what I mean. Okay, treatment here is ursodiol, but this is also can be done by the ERCP and MRCP. ERCP is therapeutic also. If you study surgery, ERCP is therapeutic also. Okay, so, and in PSC, another important point is MPO ANCA or P ANCA is important, increase in IgM is important, and another thing, yeah, here there will be pruritus also. In PBC, there will be pruritus also, and in UWorld, one question was given where they mentioned about the pathology. Yeah, so fibrosis and strictures formation. Okay, fibrosis and stricture formation. This is important. Okay, so this is all that you need to remember. Secondary, they haven't asked any question till now, so no need to worry about that. But PBC and PSC, very important questions will be asked. Just remember males and female, and which is autoimmune and which is associated with ulcerative colitis. That's it. Based on this, you will be easy to go for. So this page also is very very important. Coming to gallstones. So cholelithiasis and related pathologies. So increase in cholesterol or bilirubin, decrease in bile salts and gallbladder stasis all can clot or stone. Okay, this is important. बस आपको इतना याद रखना है these factors and supersaturation of bile with cholesterol, supersaturation of bile with calcium, bilirubinate, and this is what lead to golden stones and black stones. If they say golden stones, they are cholesterol stones. If they are black stones, or they are pigment stones. So let's just see what you need to remember here. Cholesterol stones and pigment stones. So here they will be giving you etiology. They will be asking you with what condition this can be common or this can be caused. So for most important example is Crohn disease, obesity, estrogen therapy, and yeah, that's it. This is very important. Okay, these three conditions are very important. Coming to the pigment, Crohn disease, chronic hemolysis is important, alcoholic cirrhosis is important, and total parenteral nutrition is important. Okay, in this they have asked in the UL about the chronic hemolysis. Okay, so that's it. Most common complication is cholecystitis, can cause pancreatitis, cholangitis, everything. So this is what you need to remember, the risk factors. And yeah, one more thing, the cholesterol stones are radio opaque, pigment stones are also radio opaque. The most commonly asked compound in pigment stone is calcium bilirubinate. Okay, so this is very important. All right, then. Moving on to the gallbladder pathology. The first one, biliary colic. One important thing you need to remember, the pain will be in the right upper quadrant. Nausea, vomiting will be there. Third, pain occurs after fatty meal. Pain occurs after fatty meal. Now, what is the problem occurring here? CCK after fatty meal triggers contraction of gallbladder forcing stone into cystic blood. Okay, so cholecystokinin, cholecystokinin. Yesterday we discussed about it. It is responsible for contraction of gallbladder. So it might be like because of this contraction, the stone is going into the cystic duct and something like that is happening. As a result, biliary colic is occurring. Okay, so this is important. Just remember the pain occurs after eating fatty meal. Coming to choledocholithiasis, the presence of gallstone in the common bile duct. Okay, here it was in the cystic duct. If it is common bile duct, then choledocholithiasis. That's it. Coming to cholecystitis, acute or chronic inflammation. I'll tell you the difference between acute and chronic later, but first just see what is given over here. Calculus and acalculus. Calculus means the stone will be present. Acalculus means there is no stone. Okay, so now what you need to remember here is in calculus, gallstone infection is a cystic duct resulting in inflammation and gallbladder wall thickening. Okay, that's it. Whereas in A calculus, it can be due to gallbladder stasis, hypoperfusion or infection seen in critically ill patient. Okay, अगर stone है तो calculus, stone नहीं है तो A calculus. Murphy sign. Now they will give you this Murphy sign for the diagnosis. They won't mention the Murphy sign. They will say inspiratory arrest on RUQ palpitation due to pain. मतलब they will say the physician asked the patient to breathe while inspiration there was a pain on the right upper quadrant. Okay, so this line is important. Where if they give you this line, think about they are talking about cholecystitis. Moving ahead, pain may radiate to right shoulder due to irritation of phrenic nerve. Okay, increase in ALP because we are talking about the biliary pathology here. And another thing is HIDA scan. If in the question they gave you HIDA scan, think about cholecystitis. But along with HIDA scan, read one line. Failure to visualize gallbladder on HIDA scan suggests obstruction. If you can't see gallbladder on the scan, only then the cholecystitis is occurring. Okay, so all these are very important, and this cholecystitis is very high yield. They have asked so many times. All this regarding diagnosis, they have asked so many questions. Okay, so let's just see what is gallstone ileus. Fistula between gallbladder and GI tract. Stone enters GI lumen, obstruct at ileocecal valve, can see air in biliary tree, pneumobilia, and a regular triad. We will see regular and pentatriad. Okay, so ileus is connection between the gallbladder and GI tract. So stone direct GI tract में आ गया, and the most common location is ileum. So in for gallstone ileus, they will ask most common location is ileum. Okay, so before moving forward, let's just see difference between acute cholecystitis and chronic cholecystitis. So here what is the problem is in acute cholecystitis, it will always come with a fever plus increase in TLC. They will give you something like this. Okay. And all those stuff that we did here is just a minute. Yeah, so all those stuff that they did here is like we did here is about the acute cholecystitis. So in chronic cholecystitis, for chronic cholecystitis, they will say that the person had acute cholecystitis in the history, and based on that chronic cholecystitis we can make the diagnosis. Okay, it's simple. And why you need to remember this is because the chronic cholecystitis in future it may lead to porcelain gallbladder. Okay, it may lead to porcelain gallbladder. So you should be thorough with this. Chronic cystitis can lead to porcelain gallbladder. Okay. Now, what is porcelain gallbladder? Is porcelain gallbladder is calcified gallbladder. Okay, calcified gallbladder given over here due to chronic cholecystitis, usually found incidentally. Okay, it is found incidentally. And one more thing they have asked in UWorld is increased risk of gallbladder cancer. And what type of cancer is gallbladder cancer? Mostly adenocarcinoma. So these small points are of very importance. See, this is the porcelain gallbladder. Okay, so that's it for the porcelain gallbladder. Now coming to acute cholangitis. Now cholangitis also called ascending cholangitis, infection of biliary tree usually due to obstruction that leads to bacterial overgrowth. Now this is okay, this is not important. Just remember the Charcot triad and Reynolds pentad. Jaundice, fever, right upper quadrant pain. This is Charcot triad plus mental status and shock. So they will give you either this triad or pentad, and you will be asked what condition is this acute cholangitis. Okay, so this page also becomes very high yield. All right, moving ahead. Now we have cholangiocarcinoma. Here they haven't given the image, but in UWorld they have given cholangiocarcinoma ka CT scan. Not CT, they have given the X-ray of abdomen. So cholangiocarcinoma, how it occurs is, uh, here we saw the porcelain gallbladder, like, so how cholangioma will occur is, it will occur something like this with black color. Okay, I am making it with black color, and in middle it will be white. Okay, so if something like this is given, then it will be cholangiocarcinoma on X-ray, abdominal X-ray. Okay, so for cholangiocarcinoma, they will just tell you how it has occurred. So you should be knowing porcelain gallbladder. How porcelain gallbladder occur? Chronic cholecystitis. Chronic cholecystitis, acute cholecystitis. How acute cholecystitis occur? It might be due to stone or gallbladder stasis. And how you will diagnose that? Murphy sign, HIDA scan. Okay, so all this is connected here. Now coming to the pancreatitis, the last topic of our GIT pathology. So acute pancreatitis, autodigestion of pancreas by the pancreatic enzyme. This CT scan is very important. See this pancreas. Okay, and this is very important because this is the pseudocyst of pancreas. Okay, let's just see what you need to remember here. Idiopathic, gallstone, alcohol, steroid trauma, mumps, autoimmune disease, hypercalcemia, ERCP, drug, everything. The most commonly they will be asking you about alcohol. And next one is gallstone. These two things they will be asking you so much, but lab values you have to remember. They can ask you the value of triglyceride and calcium. So both are very, very high. Okay. Now diagnose. You know the clinical presentation how it will be. So acute epigastric pain often radiating to the back. Serum amylase is increased. So in amylase and lipase, you will give priority to lipase. Lipase is more specific than amylase. Okay. And the complications are pseudocyst. This is the pseudocyst. They will give you this same image and you will have to diagnose what is this. Okay. One more thing. This pseudocyst is lined by granulation tissue, not epithelium. Okay. It's not made of any epithelium. It is of granulation tissue. Okay. It can occur. It can cause necrosis of pancreas. It can cause hemorrhage and anything it can cause. Okay. So this is about the acute pancreatitis. You need to remember a clinical presentation, pain radiating to the back. Second is pseudocyst. And third is most common alcohol and gallstone. Coming to chronic pancreatitis. Chronic pancreatitis means first acute has occurred already. Now it has progressed to chronic. The most common cause of chronic pancreatitis is alcohol use. Okay. And how you will distinguish from the CT scan? You have, see, the calcification is seen. See, the calcification is seen. In acute, there will be no calcification, but here calcification is seen. Okay. So chronic inflammation, atrophy, and calcification of pancreas. Major risk factors include alcohol use disorder and genetic problem. Okay. That's it. That's what. And amylase and lipase may or may not be elevated. So this will help you to distinguish whether it is chronic or acute if the CT scan is not given. All right. Moving on to the pancreatic adenocarcinoma, very aggressive tumor arising from pancreatic ducts. Okay. And what all you need to do is tumors are more common in pancreatic head associated with CA19-9 tumor. This is important. CEA is also there, but that is only used for screening, not specific. All right. So these are the risk factors often present with pain relating to back, as we saw in acute pancreatitis. Weight loss due to malabsorption because pancreas enzymes won't be acting. Migratory thrombophlebitis, redness and tenderness on palpation of extremity. This is the Trousseau syndrome. Obstructive jaundice with palpable non-tender gallbladder, and this is the most common line they use when they are asking about pancreatic adenocarcinoma. So this is very important. Another thing that you need to remember in pancreatic adenocarcinoma, there is some genetic mutation here, and the most common it occurs with KRAS mutation. Okay, yeah, KRAS, and yeah, this is only what you need to remember. See the pancreas. See the pancreatic tumor here. Okay, it is easily distinguished from the acute pancreatitis, chronic pancreatitis, and pancreatic cancer. With this, we finish our GIT, the complete GIT pathology. Now let's just see through the pharmacology. H2 blockers and in iron. Okay. So cimetidine is a potent inhibitor of cytochrome P450. Yeah, in the pharma part, you have to learn about the P450 inhibitors and inducers. Okay, inhibitors and inducers. See the UL for this and write down on your page, make a chart and write them down. P450 inhibitors and P450 inducers. That's what you need to remember. Okay. Nothing else in case of H2 blockers. Proton pump inhibitors are important drugs. Prazole drug. These are the prazole. It the mechanism is important. Most frequently asked. Most frequently asked. Okay. And where it is used for PUD and all those stuff. Now they will be asking you about side effect also. Increase in risk of difficult infection, pneumonia, nephritis, B12 malabsorption, decrease in serum magnesium and calcium absorption. Okay, so this is very important. PPI drugs are very important. Antacids. Okay, antacids are important. In the UL, there is one question. Why we combine aluminum hydroxide with calcium carbonate for antacid solution? Okay, actually, I don't remember the answer now, but in the UL it is given. So just see through it. And yeah, this question is there in UL and this is very important. Okay, they haven't asked in exam, they haven't asked in NBME, but UL is given. So while you solve it, you should highlight it. Okay, bismuth sucralfate, not necessary. Misoprostol, just remember the PGE1 analog, not necessary. They haven't asked any question. And octiotride, yeah, octiotride is important. Long-acting somatostatin analog inhibits secretion of various hormones. Okay, octiotride inhibits almost all the hormones. Okay, so it is used in this condition because it is inhibiting. Okay, so nausea, cramps, steatorrhea, increase in risk of cholelithiasis. This line is important. This line is important. Okay, sulfasalazine used in Crohn, so it is a sulfa drug. Okay, combination of sulfapyridine and 5-ASA. Coming to loperamide, it is mu opioid receptors, closed gut motility. This is important. They have asked so many questions. Okay. Clinical use in diarrhea, so it can cause constipation. Antiemetics, ondansetron, remember the mechanism. Metoclopramide, remember the mechanism. Ondansetron ka one thing is it can cause serotonin syndrome, and in metoclopramide they can cause extrapyramidal syndrome. Extrapyramidal means dystonia and all those that we studied in antipsychotic drug. Okay. Orlistat, this is also asked in UL. It is used for weight loss, inhibits gastric and pancreatic lipase to decrease in breakdown and decrease in absorption of dietary fat. Okay, so that's it. Anti-constipation drug, yeah, this is very important. Very important. They have asked about bisacodyl, and another thing they have asked about is docacet. So if they are asking about these two, they can ask you about anything. Remember the mechanism. Mechanism is different in all of them. Okay, remember the mechanism. बाकी कॉन्स्टिपेशन के ड्रग्स है यहाँ पे यू डोंट हैव टू फोकस ऑन साइड इफेक्ट बिकॉज साइड इफेक्ट डायरिया होगा ओके इन कॉन्स्टिपेशन साइड इफेक्ट विल डायरिया इन एंटी डायरियल ड्रग साइड इफेक्ट विल बी कॉन्स्टिपेशन इट इज सिंपल okay that's it with this we have finished GIT okay we are done with GIT let's take a 2 minute break फिर हिमैट स्टार्ट कर देते हैं आज हिमैट में we will do RBCs today okay तो मलिया जी कोई डाउट है आपको हेलो
No,
कोई डाउट नहीं है कल क्यों नहीं आए आप
I was busy little.
2 दिन से नहीं आ रहा ना आप
हाँ, it was my anniversary.
हो इट्स ओके ओके मैनी अपडेट अपडेट
हो गई।
है कोई बात नहीं तो आप रिकॉर्डिंग देख रहे हो ना मतलब रिकॉर्डिंग तो मिल गई ना आपको चेक कर रहे हो ना आप
हाँ हाँ मिल गया।
ओके 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 तो 2-3 मिनट का ब्रेक लेते हैं फिर हेमैट स्टार्ट कर देते हैं ठीक है
अच्छा।
All right, let's start then. So now we have another system that is hematology, and it's little bit difficult. Okay, like in this you have to be familiar with so many slides. Okay, so many histology slides you have to be familiar, and you have to be familiar with the lab values, because if the lab values got you wrong, you are going to make a mistake for sure over here. Okay, so lots of thing to mug up, lots of thing to memorize, and let's just start. The first that we'll be starting with is RBC disorder. We'll finish RBC today. Okay, just a minute. It just got disconnected. All right, so hematology and oncology. So first we will just see. Yeah, this question was asked to me and I didn't remember in the exam. I'm not sure whether I did the right or wrong. So this question was asked. Okay. So they gave the time period in the question, like see, they gave the time period in the question, the weeks end, and they asked where the fetal erythropoiesis is occurring. Okay, erythropoiesis means the production of RBC. Okay, so this is very important. Just remember the time period and the location where erythropoiesis is occurring. Okay, that's it. Hemoglobin development. Just remember the fetal and adult hemoglobin, the difference. That's all. Nothing. Just ignore the stuff. Okay. These are all the basic things. We are not going to detail over here. So hemolytic disease of fetus and newborn. So here, just remember one thing. Just one thing. This one thing. Yeah. Prevent administration by of anti-D IgG to Rh negative pregnant patient during third trimester and early postpartum period if fetus is Rh positive. Okay, this is very important. Anti-D IgG, anti-D IgG. Don't confuse with anti-D IgM or anti-M IgG, something like that. They will confuse you with this. Okay, so they will ask you, they will give you, they will tell you that the cases of erythroblastosis fetalis, the mother was Rh negative, the fetus was Rh positive, all those stuff they will give you. And at the end, what can you do to prevent the condition? Your answer will be anti-D IgE. Okay, that's it. Let's move forward to hematopoiesis. This is just the basic stuff of how the cells are produced. Okay, so just read them, not to remember. Here, now what all we'll be doing is this neutrophil, erythrocyte, thrombocytes, monocytes. The information you have to read. Okay, that's information you have to read. They won't be asking you direct question what is neutrophil or what, like what is present in neutrophil, what will be associated with neutrophil. They won't ask anything like this. So we won't be discussing the information over here. What we'll be doing is we'll see the images, because histology, the majority of the histological images are from hematology. Okay, so just see how the neutrophils look. Just see, okay, just see them how they look. So you should be familiar कि हाँ ऐसा दिया हुआ है, so it is talking about neutrophil. ऐसा दिया हुआ है, it is talking about monocyte. Okay, so make yourself an expert on looking at this slide, because this is going to help you. Because sometimes what happen is again the same thing in the question, we won't understand what is given, we won't even remember, but seeing at the slide we can directly make the diagnosis. Okay, so this is very important. See how platelets are. See how RBCs are. RBC basically not are like this. On if we go inward, they are biconcave in shape. Okay. Monocytes, देखो monocytes कैसे है. Macrophages. These are the macrophages. Okay, so just try to look at them as whenever you get the time. Okay, dendritic cells they won't ask. Eosinophils is important. Basophils easily identifiable. Mast cells same as basophils. Okay, but they will give you in the question they will give you allergy है या कुछ और है. Okay, so these small things are very important. Lymphocytes, natural killer cells, B cells, T cells we have already in the immunology part. Coming to the plasma cells. Now in the plasma cells, if they want to ask you any problem now, what they will give you is clock phase chromatin. Okay, clock phase chromatin. So in this, if you just in the question they will give you clear image. It's a clock phase chromatin आएगा. Okay, they will give you like this. Or if there is a plasma cell dyscrasia, okay, or plasma cell disorders है, so वो chromatin और visible हो जाएगा. Chromatin will be visible more. Okay, so these are the basic cells that you need to look out for. And yeah, remember this thing over here. A fat Santa Claus can't go far. Okay, so AFSC can't go far. But itna yaad rakho. And we will begin with the pathology. See, this platelet plug formation and all we will do when we are discussing about the platelet disorders. Now we will be just be doing about RBC, everything about RBC. Okay, so we will just do this later on when we discuss platelet. Now see another thing, RBC morphology. Acanthocytes. Acanthocytes, we saw it in A beta lipoproteinemia when we were doing biochemistry. Okay. Echinocyte कैसे दिखते हैं देखो. Dacrocyte teardrop cells. Just remember the name and the images. Schistocytes helmet cells. Degmacyte bite cells. Elliptocyte. Just see the image and remember the name. Don't try to look at the condition before remembering the name and the images or before studying the condition. Okay, because if you just try to remember that conditions now, you won't remember. But if you study the conditions in detail, if you remember the information of the condition, you will be easily able to remember कि ये इसमें होता है ये उसमें होता है. Okay, spherocytes, this is spherocytes. Macroovalocytes, oh yeah. Target cells ऐसे आता है. Sickle cells, shape of sickle. Okay, so these are the some basic RBC morphology. Another we have iron granule RBC inclusion. तो देखो इसमें ऐसे दिया हुआ है. Iron gland granules most commonly seen in sideroblastic anemia. Howell Jolly bodies, ये देखो आरबीसी के एंड पे एक डॉट है. ओके, बेसोफिलिक स्टिपलिंग इनसाइड द आरबीसी देयर विल बी स्टिपलिंग लाइक दिस. पेपेनिमर बॉडी बेसोफिलिक ग्रेन्यूल सेम एज दिस. ओके, hinge bodies like this. Okay, just see the little differences and you are good to go for hematology. Okay, so that was all about the basic. आपको पता होने चाहिए what type of cells are visible, how the cells are appearing on the slide, and based on that you have to make the diagnosis. So now we'll be studying the different types of anemia, and one basic factor how to know what type of anemia is by looking at the MCV value. Okay, whether it is microcytic, whether it is macrocytic, or it is normocytic, we have to look at the MCV value. Now, while you are solving the anemia, keep three things in mind. First, look at the MCV. Second, look at the lab. And third, look at the slide. इसके अलावा कुछ देखना ही नहीं है. You don't have to see anything else apart from this. Okay, MCV values देखो, lab देखो, and slide देखो. You are good to go for the exam. So, you know, MCV less than 80 to microcytic, 80 से 100 normocytic, greater than 100 macrocytic. So these are the examples. Give it a read and we will be discussing them one by one. Okay. BNB has explained it beautifully. But if you have used prep ladder before, so prep ladder में जो Dr. Sparsh Gupta थे, he has explained them beautifully. Dr. Sparsh Gupta has explained it beautifully. All right. Let's just go for the first condition of a microcytic anemia, that is iron deficiency anemia. All right, so let's just see what is happening here and what all you need to remember here. Iron deficiency anemia. So as we know, it is microcytic. So MCV will be less than 80. Okay. Decrease in iron due to chronic bleeding. The most common they will be asking you about GI bleeding. Okay, it can be internal, it can be external. Second, malnutrition, absorption disorder. Absorption disorder means यहाँ पे malabsorption disorder that we did yesterday. Okay, GI surgery. During the surgery there was a blood loss. Okay, or increase in demand. Example, pregnancy. Apart from this, they have, I think they haven't mentioned here. Uh, yeah, so you can write it down. This hookworm or tapeworm infection. Hookworm or tapeworm infection, because these worms are present in the intestine and they will be sucking blood, and along with that the iron also goes away. Okay, so this is important. So these are the factors that they will be providing you with. Now coming to the symptoms are also important. Fatigue, conjunctival pallor, pica, persistent craving and compulsive eating of sand or ice, the inedible substances. Okay, so see, whenever there is anemia na, whenever there is anemia, they will say a woman plus fatigue, they will definitely give you this condition. Okay, जहाँ पे भी anemia होगा, कोई भी type of anemia, may take it any type of anemia, fatigue, and most commonly they make a case of woman. Okay, now coming to the lab, coming to the lab, and this lab is what going to help you in diagnosing this condition. Okay, decrease in iron, increase in TIBC, decrease in ferritin, and the last one is here it is given. Yeah, iron, transferrin or TIBC, ferritin, and percentage transferrin saturation. This table is very important. We are not going into detail here how this occurs. Okay, this you already have studied in BNB and all those stuff, so we won't be going into detail here. There is a big process of iron absorption. If you have Robin, you can look it up. Okay, so just remember the lab values I told you. Hematology में and sorry anemia में mg value, lab values, and slide. This is what you need to look out for. Okay, so iron deficiency anemia lab values done, symptoms done, mg value done. Now see, sometimes they may also ask you this with the Plummer-Vinson syndrome. Yesterday we did. It is a triad of IDA, esophageal web, and dysphagia. Okay, in the recent NBME, they have asked about the spoon nails, coilonchia. So they will give you the image of nails. Okay, UWorld में है. In UWorld there is the image of coilonchia. Okay, so basically IDA में most common patient will be coming with gastrointestinal bleeding, hookworm infection, or pregnant female. This is the common. Lab values you know, and MCV is less than 80, and other extra things are colon care, that is spoon nails. Second is pica, that is craving of inedible substances. Fatigue, conjunctival pallor. Okay, so all these small things are there for IDA. Coming to the next condition, alpha thalassemia. Alpha thalassemia not commonly asked, but we will discuss it. You have to remember the chromosome number and trans deletion and cis deletion. This is important. Now, see, over here, just remember if minima and minor is there, no problem will be occurring. But coming to third and fourth type, hemoglobin H disease and Barch disease, they will be asking you. And if there is a gamma globulin, like gamma tetramer, okay, gamma tetramer, then they will ask you about hydrox fetalis. Okay, and in hemoglobin H disease, moderate to severe microcytic hypochromic anemia. And here, what they want to ask you is, in the question, they will ask you, what would you advise your patient? Okay, what would you advise your patient to not get married? This is the answer that they usually want. In step one also they have asked this question, and in NBME also they have asked this question. If they are asking about alpha thalassemia and in the end they say, as a physician, what would you advise your patient? Always say, don't marry, because the child will be dead. Okay, hydrocephalus will occur, child will be dead in the uterus only. So ask your patient, advise them to not marry, explain them everything. Okay, that's it. Coming to beta thalassemia, one of the most important and high yield stuff. Okay, point mutation in splice site. This was the question asked in NBME. Chromosome 11, beta globin synthesis decreases or absent beta globin synthesis. Increase in prevalence on the people of Mediterranean descent. Now, Mediterranean descent, instead of Mediterranean descent, they can confuse you. They can give you France. They can give you all the countries surrounding there, Italy, and what all countries you have written it. So for Mediterranean descent, there are two, three countries that you need to remember. Yeah, Greece, you have Spain, you don't have France, okay? Italy, Greece, Spain, and another one is Turkey. Okay, so these are the countries they might give you in the options. Okay, a patient came from Spain, Italy. So you can basically think about that. He is talking about the Mediterranean region. Okay, so now let's just see this condition: minor and intermediate, no problem. It's coming to beta thalassemia major. So here are the problems that is occurring. So let's just see what happens. It is a type of microcytic anemia with target cells. Okay, target cells will be seen here. Requiring blood transfusion, increased risk of, okay, not necessary. Crew cut on skull X-ray. This is important. Then what is important is increased risk of parvovirus B19 aplastic crisis. B19 parvovirus B19 infection is important. Can anyone tell me parvovirus B19 का classic feature, classic presentation? बोलो बोलो. Baby पे या पूजा
In
मलिया.
babies, it will present as slap cheek,
Yes, yeah, perfect,
rash,
perfect, perfect. Yeah, slabbed cheek.
and adults may.
Slap, yeah, yeah. Only this one, only this one. Okay. So slap cheek, slap face rash will be there. It means parvovirus B19 infection is there. Now coming to the lab values, increase in HbF and HbA2. Okay, HbF is fetal hemoglobin and HbA2 is the normal adult one, but here HbA will decrease. Okay, HbA is our normal hemoglobin. Okay, HbA is a normal, HbA2 is not normal, and HbF is fetal hemoglobin. So here in lab values you have to see, and they will ask कौन सा hemoglobin increase हो रहा है. Okay, so A2 will increase and F will increase. Okay, one important point. One important point over here is uh, the children will become symptomatic. Okay, I'll write it here again. Okay, I'll write here. Children will become symptomatic only after 6 months. And why? Because of presence of HbF. Okay, so HbF acts as a protective mechanism for the children till the 6 months of age. And if you diagnose the child with thalassemia, beta thalassemia in this 6 months of age, you can save this patient. You can treat this patient properly. Okay, so this is all what you need to remember. And another thing is, let's just see the images. See, this is a pallor. This is a target cells. And yeah, target cells. And see, they have given here crew cut appearance on skull. So crew cut appearance कैसा आएगा? They will give you an X-ray of skull. Okay, and based उसमें ना this hair-like appearance will be easily able to see. So this is what known as crew cut appearance. Crew cut appearance is basically military cut. Okay, तो उसमें छोटे 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 बाल होते हैं. Small hair. Okay, so what all you need to remember in beta thalassemia? Most important, increase in HbA2 and HbF. Child can be asymptomatic till 6 months of age because of HbF. Third, it is a microcytic anemia with target cells. Fourth, crew cut appearance. Okay, that's it. You need to remember here, and you will be good to go. Most commonly, the questions will be asked on HbA2 and HbF. All right. So that's all for beta thalassemia. Try to remember the target cells. Okay. Now coming to lead poisoning. Yeah, this is important. So lead poisoning, lead inhibits ferrochelatase and ALA dehydratase. We will be coming towards the heme synthesis at the end of the discussion. So what happens? It decreases heme synthesis and increases RBC protoporphyrin. Okay, that's it. Now one your common question that they like to ask is also inhibit RNA degradation. So as a result, what will happen? rRNA will be seen inside the RBC, and this is what responsible for basophilic stippling. Okay, basophilic stippling will be like this. If this is RBC, so okay, if this is RBC, so basophilic stippling will be like this. Okay, so that's what you need to know. Now, what can be the symptoms of lead poisoning? The most commonly they like to ask is lead lines. This is what lead lines is. Okay. Second, encephalopathy. Third, drop, wrist and foot drop. As you know about the radial nerve palsy, Saturday night drop. Okay. Sideroblastic anemia. Okay. So these are the symptoms of lead poisoning, and treatment is with Sakimer. You need to remember the treatment here. They have asked. One simple case that they will give you is, sorry, two simple cases I will discuss over here. Number one and number two. First case is they will say that the child was brought to old house. Okay, like they will give you that they shifted to the old house. The house was there in the family for generations. Okay, so what happens in old house are the walls are painted with lead. Okay, and you know the babies or the small children, they want to lick everything. Okay, whatever you give them in their hand, they will lick the wall, they will lick the stones and everything. Okay, so while licking the walls, the lead came into their body. Okay, so if they are giving you this case, think about this. Another case, another case is gunshot wound. Gunshot wound, the bullets are made up of lead. And the third case also they can give you about using batteries. In batteries also lead is there. So these are the three possible cases how they can ask. Most commonly is this first one, and second most common is the third one. First one, they are, if they want to ask, definitely they will go to us. Okay, so that's all about the lead poisoning. Now coming to sideroblastic anemia. Lead poisoning can cause sideroblastic anemia as well. Okay, so let's just see what is happening here. It is an X-linked defect in ALA synthase gene. X-linked defect in ALA synthase gene. It is acquired. Reversible. Alcohol is the most common cause, and lead poisoning we already did. Vitamin B6 deficiency, and drugs are isoniazid and linezolid. So all this can cause sideroblastic anemia, and you need to remember them. You need to remember all the causes. Okay. So now see the lab finding. Here the lab findings are totally opposite to those of IDA. Okay, so it is not given over here. You can write it down. Sideroblastic anemia. If serum iron decrease in IDA, it will increase here. In TIBC, it will decrease. It will increase. It will increase. Exactly opposite to IDA. So just remember the lab values of IDA. You are good to go with sideroblastic. Okay. So we are done with sideroblastic. Let's just see what else can be seen. Basophilic stippling, as we already discussed in the lead poisoning. And the second one is you will be seeing ringed sideroblast. So this is what ringed sideroblast is. Okay, what is happening here is let me just show you. If this is RBC, sorry, if this is RBC, this is what ringed sideroblast looks like. Okay, so ringed sideroblast and basophilic stippling I already discussed. So these two are seen in sideroblastic anemia. Lab values you know. Okay, so these are the important things that you need to remember for, I think, microcytic anemia. Four types of microcytic anemia: IDA, uh, thalassemia, third is sideroblastic anemia, and lead poisoning as the cause of sideroblastic anemia. And one more type of microcytic anemia I am missing. Can anyone tell me? Pooja, Malia, any answer? What about anemia of chronic disease? It is microcytic as well as normocytic also. It falls under the both the category. Okay, we will discuss that in the normocytic only. So that's all about the microcytic anemia. Just remember the lab value, look at the slides, and you're good to go. Okay. Now coming to the macrocytic anemia. The one and only important condition of macrocytic anemia is megaloblastic anemia. Okay. Here MCV levels are going to be greater than 100 as already written there. And what else is there? He sometimes instead of asking the diagnosis, they will ask you what is impaired here. So impaired DNA synthesis is important. Okay. Just let me give you a general idea. There will be B12 deficiency and B9 deficiency. Okay. You already know how to distinguish between the B12 and B9. We did this in the biochemistry. So if it is a B9 deficiency and B12 deficiency, if B9, so there will be increase in homocysteine, but methyl malonic acid will be normal. If we go for B12, homocysteine will be increased and methyl malonic acid will also increase. Okay, in B12 both of them increase. In B9 only homocysteine will increase. Why this happens? Look at the biochemistry video. I have explained it in the flowchart only. Okay, so let's just quickly see what can be the causes of B9. In the B9 they will give you either alcohol or they will give you this drug, methotrexate or phenytoin drug. Okay, if we go for B12, it is either pernicious anemia, Crohn's disease, and veganism. Okay, because of veganism. And this is the diphyllobotrium latum, that is fish tapeworm, that will be covering in microbiome and the parasitic infection. Okay, very simple. And one important point you need to remember here is there will be hyper segmented neutrophils. Okay, hyper segmented neutrophil. So again done. Three features that you need to remember in megaloblastic: MCV greater than 100, hyper segmented neutrophils hoga. Third, it can be either due to B9 or B12. If it is B9, homocysteine will be increased, but if it is B12, both homocysteine methyl malonic will be increased. Okay, coming to the risk factors, B9 में आपका क्या होगा? Alcohol and phenytoin methotrexate. Whereas in B12, all the remaining, that veganism and pernicious anemia and all those stuff. Okay, simple, simply done. Now, one case that they like to ask here is during GIT surgery, ileum was removed. What will happen? Answer is megaloblastic anemia. Actually, many things happen, so that is for the case of step 2 CK. But in step 1, what common answer that they want is megaloblastic anemia, because B12 at the end is absorbed in the ileum. Okay, अगर ileum होगा ही नहीं, so how the B12 will be absorbed? So if ileum is removed during the surgery, megaloblastic anemia is one of the most common, and they will be asking you the question like this only. Okay, they won't ask you directly like this only, they will be asking you. Okay, now B12 and B9 ka deficiencies we have already done in biochemistry, so I'm not going into detail over here. Okay, let's look at the orotic aciduria. Orotic aciduria, differential diagnosis with OTC, ornithine transcarbamide deficiency, that we saw in the urea cycle. Okay, so let's just see what is given here. Inability to convert orotic acid to UMP. Okay, this we've seen in the pyrimidine synthesis pathway. Defect in UMP synthase, it is autosomal recessive. Here there will be no hyperammonemia. Okay, whereas in OTC there was hyperammonemia. Orotic acid you will see in both OTC also and orotic aciduria also. But hyperammonia is the deciding factor how you will be differentiating it. Okay, so this is very important. Just make it done. And this they have given in UL. One question was there but not directly asked. They have just given triphalangeal thumb. So if they ask about triphalangeal thumb, just remember non-megaloblastic anemia with MCV greater than 100. Okay, MCV will be greater than 100, but it is non-megaloblastic anemia, and they will give you triphalangeal thumb. Okay, that's it. So we are done with macrocytic anemia also. So 3-4 things you have to remember in each anemia, and you are good to go. Hypersegmented neutrophils का यहाँ पे फोटो नहीं दिया, दिया see here only. Okay, so this is what hypersegmented neutrophils look like. If it was normal, it would have been like this, but normal nahi hai. There are so many segments. So hypersegmented neutrophil is very important in making a diagnosis. Now coming to the last type of anemia, that is normocytic, normochronic anemia, and we will be talking about various types of hemolytic anemia. Okay, and this is where you will be facing a lot of confusion. So let's just quickly do it and end our tutor class. All right, normocytic normochromic anemias are classified either as non-hemolytic or hemolytic. The hemolytic are further classified according to the cause of hemolysis, intrinsic or extrinsic, okay, or intravascular or extravascular. Now, intrinsic extrinsic means it is occurring inside the RBC or outside the RBC, and intravascular extravascular means it is occurring in the blood vessel or outside the blood vessel. Simple terms, okay. Now, one thing you need to remember here is hemolysis can lead to increase in LDH, reticulocytes, unconjugated bilirubin, gallstones, and urobilinogen in urine. This factor we always forget because it is just given over here. And when we go to the next page, when we are studying the different types of hemolytic anemia, we forget them. Okay, so just remember one thing: hemolytic anemia may it can be anything, spirocytosis, or you have PNH, or you have any other type of hemolytic anemia. This is must. LDH increase, reticulocyte increase, bilirubin increase, all those stuff. Okay, and why this occurs? Because of breakdown of hemoglobin in RBC. Okay, so hemoglobin की वजह से ये सारी चीजें हो रही है. All right, let's just see intravascular में क्या है and extravascular में क्या है. In intravascular there is decrease in haptoglobin, increase in schistocytes on blood smear. In extravascular, macrophages in spleen clear RBC. So findings can be splenomegaly. Here there won't be splenomegaly. Okay. Here there will be splenomegaly. It's okay. Don't remember here now. But when we study one by one disease, you have to remember that. Okay. So for now, just remember the basics of hemolytic anemia, how it is occurring because of the breakdown of heme. So now when we are thinking about breakdown of heme, you will be remembering all other factors also like increase in LDH, reticulocyte, bilirubin increase, all those stuff. कोई भी hemolytic anemia हो, you should be having all this. So don't get confused. Okay. Now let's see the first type of non-hemolytic anemia. We'll discuss first non-hemolytic anemia. So here LDH and all those stuff won't be increased. Okay. ये सब यहाँ पे increase नहीं होगा. It was only increasing in the hemolytic. Here we are talking about non-hemolytic. So let's just see our first AOCD, that is anemia of chronic disease. Mark my words, anemia of chronic disease also occurs in microcytic anemia. Okay, and MCV either can be less than 80 or between 80 to 100. Actually, how to decide whether it is microcytic or normocytic? For this, you have to go into detail because there are two factors: whether it is occurring in liver or it is occurring in bone marrow. Okay, there are two factors, and based on these two locations, they will be deciding whether it is microcytic or normocytic. But that's not our concern here. We just have to see how to diagnose AOCD. I will give you one simple clinical vignette. How they like to ask is they will give you MCV values, they will give you symptoms of anemia, and along with that, okay, along with that, they will give you any chronic condition. And this chronic condition can be anything. Most commonly, they ask about rheumatoid arthritis. Okay, so chronic conditions like rheumatoid arthritis, you need to beware in mind, keep this in mind. And if you see any chronic disease is occurring along with anemia, think about anemia of chronic disease. So let's just see what else you need to remember here. Inflammation, increase in IL-6, increase in hepcidin. Okay. So decrease in release of iron from macrophages and decrease in iron absorption. That's it. They have given you chronic infection. So that is chronic kidney disease, autoimmune disease, HLE, RA, everything will be included. Now see the lab values of chronic disease. Iron decrease, TIBC decrease, ferritin increase, and it can be normal or decrease. It is completely different than IDA and SA. Okay, so you need to remember. Yeah, I'm sorry, but you have to remember. You can't do anything. As I told you, MCV values, lab values, and slide. That's all you need to do for anemia. Okay. So that's all. Nothing else can be done. And if they ask you about the treatment, so you will select treat the underlying cause. To treat the underlying cause, may if it is rheumatoid arthritis, so you will be giving drugs for rheumatoid arthritis, something like that. Okay, simple. Just remember the lab values and just remember the clinical vignette. Coming to aplastic anemia. Okay, aplastic anemia, as I was explaining while I was discussing about the GIT, whenever you see white globules on the slide, whenever it will be related to fat. Okay, it will be either related to fat, and another condition is it can be hypocellular. Okay, because there are no cells, it's completely white. Okay, so either hypocellular or fat. Okay, in GIT I was talking when I was discussing hepatic steatosis. Okay, hepatic steatosis. And yeah, I forgot to tell you one thing in GIT. Along with hepatic steatosis, you can find this in Ray's syndrome also. Pooja, can you tell me Ray's syndrome? What is Ray's syndrome?
Yeah, Ray's syndrome is hepatic encephalopathy occurring in children who took aspirin for flu
Yeah,
or
yeah.
um, yeah,
Okay, only flu,
varicella
only
zoster.
flu or any other thing can also. Most common apart from flu.
Varicella zoster
Yeah, yeah, perfect. So how would the presentation of varicella zoster will be there? What would be the presentation? Yeah,
along a particular dermatome.
yeah, yeah, yeah,
There'll
yeah.
be
Got it, got it.
basically
Yeah, shingles. There will be shingles. Okay. So yeah, so because in that also there is defect in the oxidation of fats in the by the mitochondrial enzyme. So there also they can ask you steatotic appearance on biopsy. Okay, so just add this in the Ray's syndrome. Here also you can get this steatotic appearance. Okay, so let's just come back to our discussion. Aplastic anemia. If you see the image like this, straight away go for aplastic anemia, and what will occur? There will be pancytopenia, hypocellular bone marrow with fatty infiltration. See, I told you fatty infiltration. Whenever you see white globules, this is a general pathology rule. Whenever you see the white globules in the slide or biopsy or bone marrow, aspirate or anywhere, just think that the question is asking regarding fat. Okay, that's it. So here important one is how aplastic anemia occurs. They will give you the example of radiation. Okay, the radiation can be anything, either MRI, X-ray, anything. Let's just discuss about important condition that is Fanconi anemia. So some of the symptoms of Fanconi anemia are, please write this down: short stature. Second is cafe au light spots, heart, renal, eye abnormalities. And another thing is abnormal thumb. Here also there will be abnormal thumb. Okay. And another thing that you need to remember for aplastic anemia is drugs. So benzene, chloramphenicol, and all the anti-tumor and anti-metabolite drugs. Okay, anti-tumor and these are all anti-tumor drugs. Okay, so what to remember in aplastic anemia? The drugs you need to remember. Fanconi anemia you need to remember. Third, it will be fatty infiltration on the slide, and radiation. These four things you need to remember. Okay, so with this we are done with non-hemolytic anemia. Okay, normocytic, non-hemolytic anemia. Note this down and we'll go towards the hemolytic anemia. All right, let me just explain you from somewhere else because there is so much of information already written over there. Uh, I'll just erase it. All right, let's just begin. So first one that we are going to discuss is, okay, the first one that we are going to discuss here is the intrinsic hemolytic anemia. Okay, intrinsic hemolytic anemia means the defect is under inside the RBC membrane. Okay, so let's just see what all important ones are: hereditary spherocytosis, G6PD deficiency, and next one is sickle cell anemia. These are very high yield. Remaining one, that is PNH and pyruvate kinase deficiency, they are not frequently asked, but you will have one question for each one of them. But these three conditions that I have marked, you will have so many questions. Okay, so let's just first discuss about hereditary spherocytosis. So primarily autosomal dominant due to defect in proteins interact with RBC membrane, and these proteins are ankyrin band 3 protein. This protein you need to remember. Okay, another thing, small round RBCs with no central pallor. So as we saw earlier in the slide, no central pallor will be there, but normally RBCs have central pallor. Okay, normally RBCs have central pallor, like these are RBCs, but in spherocytosis there will be no pallor. Okay, and one important point that I want you to know, how you will distinguish whether the question is actually talking about hereditary spherocytosis. It is the only condition where they will give you increase in MCHC. Only condition where they will give you this lab value, and only condition where you need to focus about it. Okay, remaining all, they won't even, they won't give this. Okay, but in hereditary spherocytosis they will give this. Okay, so let's just see what next we have to do. Splenomegaly is going to be there. Pigmented gallstones, aplastic crisis, that is parvovirus B19 infection. Now diagnosis, they will in the question they will ask you about diagnosis. So decrease in mean fluorescence of RBCs in EMA binding test, increase in fragility in osmotic fragility test. This is the most commonly they give. Increase in fragility in the osmotic fragility test. Okay, and what we need to do? Yeah, treatment is splenectomy. Now, don't confuse yourself with one thing. We studied over here. Okay, we did this over here. All these symptoms are going to be there. LDH, reticulocytosis, unconjugated bilirubin, everything will be there. So along with this, these are the special features of hereditary spherocytosis. Along with this, okay. So make sure you don't forget those symptoms that we did in the earlier page. Okay. And one important thing here was, yeah, yeah, that's it. I've covered pretty all. Okay. So in hereditary spherocytosis, no central pallor, MCHC is high. You have to remember the protein's name. Splenomegaly is important. Treatment is splenectomy. And the last one is osmotic fragility test. And remember EMA binding test also. Okay. Just one word for all the cases. Coming to G6PD deficiency, we will do for G6PD, then we'll come to PNH. G6PD deficiency. Now for G6PD deficiency, it is X-linked recessive G6PD defect. Now see, these arrows are very important. Decrease in NADPH, decrease in reduced glitter ion, increase in RBC susceptibility to oxidative stress. These arrows are very important. They will ask you. They will give you these three conditions only, and then they will ask you this questions like this. UL has it. NBME has so many. Okay, so make sure you know these arrows properly. Another thing they like to ask: sulfa drugs and fava beans. Anti-malarials are also sulfa drugs only. But fava beans. Fava beans is something new and unique, so that you can remember that if we're talking about fava beans, this is period deficiency. Okay, and here also most common among Mediterranean countries. So you all already know what are the Mediterranean countries. Okay, Italy, Greece, Turkey, Spain. It can cause both extra and intravascular. Now coming in here, the symptom, it can be back pain, hemoglobinuria for few days after stress, lab decrease in GCHPD activity, and yes, one important point, hinge bodies and bite cells. Hinge bodies and bite cells. Frequently asked. This question is frequently asked. Hinge bodies and bite cells. So what all you need to remember for GCHPD deficiency? LDH increase, unconjugated bilirubin, all those stuff will be in general. Coming to specially, they will give you fawabins or antimalarials or sulfa drugs. Then they will give you decrease in NADPH, decrease in reduced glutathione, increase in RBC susceptibility to oxidative stress. In the symptom part, they will give you back pain and blood in urine, not actually blood, hemoglobin in urine, and hind bodies and bite cells. Okay. So at the end of the hematology class, what you do is you write the name of conditions and write down what cells are found. Okay, because the in the beginning of the chapter that they have given is now, in that they have mixed so many things, and that so many things are not necessary over there. So what you do is the disease that you have studied today, write that what name of a disease and just write down what can be seen in the slide. One or two appearance, not more than that. Okay, so just do this thing after you finish hematology. Coming to the next, that is sickle cell anemia, very, very, very high yield. Okay, so you can see the appearance, sickle cell shape. Okay, appearance so yahi hai. Now coming to what happens here, point mutation in beta globin gene, तो glutamic acid से valine में change हो जाता है. Mutant HBA is termed as HBS. So HBA that was normal. So here instead of HBA it will be HBS. So you got the lab value. HBS will be increased over here. Now see, here pathogenesis is very important. Low O2, high altitude or acidosis, precipitate sickling. Okay, anemia, vaso-occlusive. This paragraph is very important because they will give you low O2 or high altitude acidosis. They will give you any of the case. Okay, the patient went to the high altitude place. What all conditions can occur, and in that, in one of the options, they give sickle cell anemia. Okay, so you have to think about that. Now here also same thing as thalassemia. Newborns are initially asymptomatic because of HbF. Because of increase in HbF, HbF acts as a protective factor for HbF is a fetal hemoglobin. Okay, HbA is converted to HbS, but HbF can't be converted to HbS till you are in the childish age. Okay, so keep this in mind. Now, because of this, heterozygotes have resistance to malaria. Okay, so just remember this and see some of the symptoms of thalassemia are similar in sickle cell anemia. Let's just see which one. Crew cut on skull X-ray. Okay, so this was the X-ray and this is what the crew cut looks like. And yeah, sickle cells are the crescent shaped RBCs. We saw here already crescent shaped RBCs. Now complications. Aplastic crisis due to parvovirus B19. You will be seeing Hobble Jolly body over here. Clinic infarct. Salmonella osteomyelitis. One important point. Osteomyelitis associated with sickle cell anemia. Okay, so for example, if they gave you a case of sickle cell anemia, okay, and then they ask what is the bone problem here, so you will say osteomyelitis, and the most common organism responsible is staph aureus. Okay, most common, sorry, not staph aureus, salmonella. Okay, so salmonella is responsible for osteomyelitis in sickle cell anemia. Painful vaso-occlusive crisis, let's just see what is there. Dactylitis, painful swelling of hands and feet. Priapism, priapism is the painful erection of penis. Acute chest syndrome, respiratory distress. Okay, and avascular necrosis, sickling in renal medulla, renal papillary necrosis. When we were doing the renal disorder, renal papillary necrosis had association with sickle cell disease. Okay, and one more thing, what is the most common cause of that in sickle cell anemia is respiratory distress. You will be seeing pulmonary infiltrates on CXR. Okay, so all these points are very important. Sickle cell anemia is itself a very high yield disease. Now coming to the lab values, as I told you, HbA is going to decrease. HbF will increase because of fetal hemoglobin and HbS. HbS is what the mutated hemoglobin is. Okay. Treatment is hydroxyurea. Why hydroxyurea? Because the mechanism of hydroxyurea is convert HbA into HbF. So if HbF is there, it will act as a protective mechanism. Okay. So these are all the sorry. Yeah. So these are all the stuff that you need to remember while you are doing sickle cell anemia. And mark my words, these are going to be asked in exam. What will happen is in the exam, they will make the language difficult. So as a result, you become confused. Okay, but you have to just pick out the lab values and one or two highlights in the question. All right. Coming to the paroxysmal nocturnal hemoglobinuria, PNH. Hematopoietic stem cell mutation, increase in complement mediated intravascular hemolysis. Complement mediated. So here what they will ask is PIGA mutation, impaired GPI anchor synthesis for decay accelerating factors DAF and CD5. Okay, so this is what you need to remember. And membrane inhibitor of reactive lysis CD59 which protect RBC membrane from complement. Now what they will give you here is in the exam they will give you a test tube with a urine and the urine color will be different. Either it will be yellowish and tints of red. So something like this they will be giving you. They will give you a test tube only with a urine. Okay. So it will give you pink red urine in the morning and in the lab they will give you CD55 59 class. This will they will give you definitely they will give you this and straight away you have to go for PNH. Okay, straight away. So only 3 points you need to remember. DAF CD55 deficiency, CD59 deficiency. In the exam, they will give you a test tube with abnormal urine color. Okay, that's it. And in the lab values, I told you 55 and 59 deficiency. Okay, so this is what you need to remember for PNH. Moving on to the last condition of intrinsic hemolytic anemia, we have pyruvate kinase deficiency. So what happens here is pyruvate kinase defect, decrease in ATP, extravascular hemolysis, increased levels of 2,3-BPG. Okay, 2,3-BPG. Go back to the biochemistry part, increase in 2,3-BPG. So what will happen here is hemolytic anemia in newborn and blood smear shows birth cells. In pyruvate kinase deficiency, you have to remember birth cells. Okay. So with this, we are done with intrinsic hemolytic anemia. I have explained you in each and every disease what you need to focus on. Okay. So just one or two words and you are good to go for diagnosis. Now coming to extrinsic hemolytic anemia. Let's just see. Extrinsic hemolytic anemia and the most common one is AIHA, autoimmune hemolytic anemia. Now how to clearly diagnose it? Let's just see. You have to look for the Coombs test. So they will give you Coombs positive. Okay, Coombs positive. All right. For warm IHA and cold IHA. Okay. In warm there is IgG, in cold there is IgM. How to remember? Warm IHA hai, so IgG warm. Goa is always warm. Okay. Cold IgM. Manali almost cold. Okay. So warm IgG, cool IgM. This is how you will be remembering what antibodies will be there in it. Okay. So let's just see. We have to remember these conditions over here. SLE and CLL. In cold, you also have to remember CLL and Mycoplasma pneumonia infection. Okay. Another thing that you need to remember in the slide, they will give you spirocyte as well as agglutinated RBC. See, agglutinated RBC. RBCs are stick to each other. Okay. So this slide is very important for IHA diagnosis. Okay. That's it. Only 3 points. Warm or cold में कौन सी immunoglobulins है? What all it is associated with? And third, the RBC aggregation. Okay. Coming to MAHA. Actually, there are two types of MAHA, but we will give MAHA and MAHA. Small MAHA is microangiopathic hemolytic anemia. So here RBCs are damaged when passing through obstructed or narrow vessels. ये narrow vessels है. Already there was some thrombosis or emboli formation over there, and RBCs are damaged while passing through them. Okay, simple. So what happens here? What you need to remember here is schistocyte, helmet cells. We saw this before. Okay, helmet cells, schistocyte. And another thing is it is seen in TTP-HUS and HELP syndrome. Okay, that's it. That's it. Schistocyte दिख रहा है, MAHA. Coming to macroangiopathic hemolytic anemia, यहाँ पे भी आपको schistocyte दिख रहा है. Okay, what is the difference? Prosthetic heart valves and aortic stenosis may cause hemolytic anemia by mechanical destruction of RBC. This line is important. Okay. Mechanical destruction of RBCs due to prosthetic heart device, and destruction of RBCs because of obstruction in the blood vessels. Both are different. Microangiopathic, macroangiopathic, but in the slide you will see schistocytes only. Okay, so this is how you will be distinguished between micro and maha. Infection may malaria and babesia. Okay, no need to do about it. Ignore these leukopenias, and I think we are almost done. One last topic we need to cover up today: heme synthesis. Okay, and अगर हो सके remember this, remember this cycle, because what will happen here is no, sometimes you will be forgetting between this and this, you will be confused between this and this. Okay, now let me just tell you. uh, okay, so first one, lead poisoning, we already did, so no need to discuss it again. Okay, but enzyme ALA dehydratase and ferrochelatase, you have to remember the enzyme. Okay, coming to acute intermittent porphyria. So here the enzyme is porphobilinogen deaminase. Where is porphobilinogen deaminase? Here. Okay. So they might ask you increase in levels of porphobilinogen or decrease in levels of hydroxymethyl or decrease in levels of uroporphyrinogen 3. They will ask you like this. Okay. So see, accumulated substrate I told you, porphobilinogen increases, and symptoms you need to remember: pain in the abdomen, port wine colored pee, polyneuropathy, psychological disturbances, and that's it. Okay, they will give you any of these factors. Port wine color, they will give you port wine color. They will give you pain in the abdomen, and they will give you polyneuropathy. It means there was tingling sensation, there was no sensation in the hand and feet, and something like that. Okay, that's what acute intermittent porphyria is. Coming to porphyria cutanea tarda, here the enzyme deficiency is 0-porphyrinogen decarboxylase. See here. Okay, so there will be no conversion here. Okay, so porphyrin is increased, tea colored urine. Now what will happen here is the symptoms will be same for both. Symptoms will be same for both, with one minute difference. Blistering cutaneous photosensitivity. There will be blisters and there will be hyperpigmentation. So there will be dermatological problem. Okay, that's it. That's what you need to remember. Sometimes they can associate with hepatitis C. That's it. The two differences of heme synthesis. Okay, acute intermittent porphyria cutanea tarda. So just remember this. Sometimes what they ask is in one of the NBMEs, what they ask is they ask the process. So if they said in acute intermittent porphyria, which type of heme synthesis is defective? So we had to answer conversion of porphobilinogen to hydroxymethylene. That's why I'm telling you to remember the cycle. In porphyria cutanea tarda, they ask defective conversion of uroporphinogen 3 to uroporphinogen 2. So this is what they are asking. And another important thing is they can ask what is the substrate for this like heme synthesis. So your answer will be succinyl CoA plus glycine. Okay. So these two conditions I told you how to differentiate it. This lead poisoning we already studied before. And let's just see, are we left with anything? Iron poisoning not needed. Just remember hemochromatosis that we studied in GIT. Okay. So with this we are done with RBC. Uh, yeah, RBC. I will recap it. Just a small thing. Look at the MCV values, look at the lab values, and look at the slides. Okay, you are good to go. अगर आपने ये सब master कर लिया, you are done. And try to constantly look more and more at the histological slide. That is what going to boost up your score in hematology. Okay. Uh, and when you solve, you will do one thing. When you have the hematological question, save that hematological image in the note. Okay, or the flashcard. So that's it from my side. We finished today's class. We finished GIT and we did hematology, RBC disorder. Okay, I hope you don't have any doubt. Everything was clear how the questions will be framed. And maybe tomorrow we won't have class. I'll inform you by afternoon. On Monday, we'll continue with WBC and platelets. And if the time persists, we will start our next system, musculoskeletal. At least I will try to finish dermatological part in that. Okay, so that's it. And if you have any doubt, just stay back or else the class is over. Yeah, Pooja. नो डाउट। मलिया कोई डाउट?
Hmm.
क्या हो गया, नींद आ गई?
Yes, I'm exhausted.
क्या हुआ?
I'm exhausted.
ओके ओके, तो मैं ये कह रहा था कि बाकी तुम्हारा कैसा चल रहा है सब?
Baki, like I'm revising the systems and doing the blocks. Okay,
हम्म।
but फिर 2 days से थोड़ा break हो गया. Again, from tomorrow I
ओके
will
कोई बात
start.
नहीं, बट युवल के साथ रेगुलर हो ना? 2-3 दिन ब्रेक
हाँ.
हो गया ठीक है, बाकी तो यू आर रेगुलर राइट? स्कोर इंप्रूव हो रहा है?
Yes, yes,
हो रहा
yes,
है ना? ओके, इफ यू
yes.
हैव एनी डाउट जस्ट लेट मी नो। ओके,
Okay.
ऑलराइट।